Hello, my name is Claudio Rabec. I am a pulmonary physician and I work in the University Hospital at Dijon in France. I am in charge of the breathing sleep disorders and the home ventilation unit in this hospital in the pulmonary department. And I am going to talk about some important issues in home mechanical ventilation. Monitoring long-term mechanical ventilation is a very important issue. We have several tools to evaluate quality of ventilation in long-term mechanical ventilated patients. The first of that is diurnal PCO2. Second is overnight pulse oximetry. The third is the evaluation of nocturnal kinetics of CO2 by using transcutaneous PCO2 or end-tidal CO2. After then, in a step-by-step approach, we can use the built-in monitoring devices coupled to the ventilators. And the last but not least way to evaluate quality of ventilation is a complex assembly by using polyrography or polysomnography. So, first thing first, when we have to evaluate quality of ventilation, we have simple tools to evaluate this quality of ventilation. And this is the usual assessment performed by most of the teams that are interested in long-term mechanical ventilation. This assessment includes clinical results, arterial bulb gazes, and overnight pulse oximetry under ventilation. When we analyze this basic pack in front of therapeutic goals to be achieved with long-term mechanical ventilation, this basic pack is able to evaluate patient satisfaction, diurnal PCO2, SpO2, and to ensure also that there is not apneas under non-invasive ventilation, because oxygen saturation is a key tool to evaluate apneas under this technique. These apneas are expressed at the saturation dips under ventilation. I am going to speak about the different elements that are included in the basic pack. Firstly, let me introduce some words about arterial bulb gazes. As you know, the main characteristics of a patient with respiratory failure is in alteration in gas exchange. So, arterial bulb gazes is a main marker of a quality of ventilation. But the problem of arterial bulb gazes is that there are a punctual measurement, firstly, and after then that is an invasive measurement. So, a possibility is to perform repeated arterial bulb gazes, but is not useful in the routine use. Two studies published recently focus about the efficacy or the accuracy of diurnal PCO2 to evaluate nocturnal quality of ventilation. And in fact, as is shown in this slide, these two trials show that even in a patient in which diurnal PCO2 is normal, it is possible to have nocturnal hypoventilation as evaluated by nocturnal capnography. What about overnight pulse oximetry? Pulse oximetry is a very important tool to evaluate quality of ventilation. It's very sensitive to detect breathing abnormalities, is non-invasive, is easy to perform and available, allows a continuous monitoring differently from arterial bulb gazes, and can be even performed at home. But even if nocturnal pulse oximetry is a very interesting tool, in presence of oxygen desaturation, we are not able to discriminate between different mechanisms that could explain this abnormality. Because oxygen desaturation could express both sleep-induced hypoventilation, but also sleep-induced BQ abnormalities. And in this context, the therapy of both conditions is different, because if you have a residual hypoventilation, you have to increase amount of ventilation. But if the mechanism is oxygen saturation related to abnormalities in ventilation perfusion relationship, the more pathophysiological treatment is to provide an oxygen added to the ventilator. So, nocturnal pulse oximetry is a very sensitive tool to detect abnormalities of ventilation during the night. But a good question is, if you have a normal oxygen saturation, does it make it possible to be sure that a patient is well ventilated? Let me show in the next slide a pulse oximetry trace performed in a neuromuscular patient. As you can see, mean saturation is 97, 98. There is a little desaturation, but never below 95. But if you add to this picture transcutaneous capnography, you can see that the patient moves all the night in a mean of 50 millimeters of mercury of transcutaneous PCO2. That is, even if the oxygen saturation is normal, the patient hypoventilate. And as you can see, there are two periods almost not expressed in oxygen saturation, with an increase in PCO2, that is probably the expression of hypoventilation during REM sleep. This inequality between nocturnal pulse oximetry and transcutaneous PCO2 could be explained by the particular form of the curve of oxyhemoglobin. As you can see, in the last part of the curve, a great variation of PaO2 is not reflected as a variation in oxygen saturation. So, if a patient has a high level of PaO2 during the night, oxygen saturation is not a sensitive tool to evaluate ventilation. This complex interaction between oxygen saturation and the transcutaneous PCO2 is reflected in this slide. These are data published by our group that show that even in patients with a normal overnight SpO2, even at a high cutoff of normality, that is 95% of oxygen saturation, more than 20% of patients could be hypoventilated during the night. This is a trial conducted in ventilated patients, and as you can see, these patients are not well ventilated, but oxygen saturation is not able to reflect that. So in summary, a normal overnight SpO2 reflects a non-optimal nocturnal oxygenation, even if it's not able to allow us to discriminate between two different mechanisms. But the normal saturation does not allow us to exclude nocturnal hypercapnia. In particular, in patients in which basal level of PaO2 is high, but also in patients with supplementary oxygen. So, overnight SpO2 is necessary, but not sufficient. So, we have to find new tools to improve the evaluation of quality of ventilation. And in this context, the evaluation of the kinetics of CO2 during the night is a main tool to define if patient is well ventilated or not. This evaluation of nocturnal PCO2 could be obtained by two different tools. The first is transcutaneous PCO2, and the second is end-tidal CO2. Let me introduce firstly some important concepts about transcutaneous PCO2. There are several devices nowadays commercialized in Europe and United States that allow us to evaluate kinetics of transcutaneous CO2 during the night. What about the principles of transcutaneous PCO2 measurement? It consists to warm the skin to increase the transport of CO2 to the surface of the skin. At the surface of the skin, a chemical reaction will transform CO2 in hydrogenium, and we will measure with a sensor the pH of the skin. And this variation in pH of the skin is a reflection of variation in PCO2. The second tool to evaluate kinetic of CO2 is end-tidal CO2. This tool is very used in critical care monitors to evaluate non-invasively CO2 kinetics in patients under invasive ventilation. Some new ventilators allow us to evaluate these kinetics by using the sensors of CO2 that are included in the ventilator. And the more interesting is that we can evaluate together end-tidal CO2 and oxygen saturation by connecting in the device two different sensors. So let me show you some pictures that reflect that. This is an example of a device that included two different sensors to evaluate both end-tidal CO2 and oxygen saturation. In this picture, you can see the CO2 expiration curve. This reflects the kinetics of CO2 exhaled during a normal breath. As you can see in the last part of this curve, there is an increase in CO2 that is expression of the CO2 present in the alveoli. This alveolar CO2 is a very, very good marker of arterial PCO2. We are able to know arterial PCO2 levels. This kind of ventilator allows also to see in the screen of the ventilator the measure of CO2 during ventilation. But also it is possible to see that in an online connected computer, but also what using a software to see this data in a delayed mode. As you can see here, you have a screen capture of software of one of these ventilators that show a very, very beautiful end-tidal CO2 curve. But also you can compress that and show the trend of end-tidal CO2 during the night. That is an expression of variation of arterial PCO2 under ventilation. It is very interesting that this type of device allows us also to evaluate oxygen saturation by evaluating both SpO2 trend, and you can see in this picture a 7 hours trend of oxygen saturation. But also, if you decompress the recording, you are able to evaluate the data of one period during the night. And as you can see in this picture, there are the saturation dips under non-invasive ventilation that are an expression of apneas in these patients. More interesting yet is that you can combine these two tools to evaluate both end-tidal CO2 and oxygen saturation in a different mode to evaluate on the morning the quality of ventilation during the night. So this improved pack, by adding evaluation of kinetic of CO2, add to the evaluation of therapeutic goals the assessment of nocturnal hypoventilation. So sometimes basic tools, even by using kinetic of CO2, are not able to deeply evaluate quality of ventilation. And it's in this context in which we need to use more advanced evaluation of quality of ventilation. And we have nowadays two important tools to perform that. The first are monitoring systems coupled to home ventilators, and the second is the gold standard, that is polyrography or polysomnography under ventilation. Let me begin by speaking about monitoring system coupled to home ventilator. Some new ventilators allow us to evaluate some data provided by the ventilator and coupled them with oxygen saturation or other biological markers. In fact, we have three different types of devices. The first type of devices are the more basic devices, and there are devices that allow us to downloading ventilator trend data. That is, we have a trend, an overnight trend of different signals. The second type of device allows us also to evaluate raw data, that is to see in detail flow, pressure, and volume curves. And after that, last but not least, some devices allow to combine ventilator data with biological markers. This is a screen obtained for a software of a built-in monitoring device coupled to a ventilator. As you can see here, you have several signals provided by the ventilators. First is the pressure provided by the pressure sensor inside the ventilator. Second is flow provided by a pneumotac included in the ventilator. You have also minute ventilation as estimated by the device and leaks as estimated also by the software. Additionally, you can see in this slide oxygen saturation as a biological marker, but also in the top of the picture you can evaluate if patient trigger or not ventilator. When the box is yellow, that means that patient did not trigger the ventilation, and this is a control mode. And when the picture is green, it means that patient triggered the ventilator. As you can see here, you have a very regular ventilation in a 5-minute page with no leaks and normal saturation. So this screen allows us to evaluate in detail the quality of ventilation, but also the patient-ventilator interaction. I can say by seeing this picture that my patient during this period is probably well ventilated. But also, this kind of device and this kind of software allow us to decompress the recording and to see more details concerning this period of ventilation. As you can see here in this page, there is regularity in the ventilation, but here the patient triggered the ventilation because the boxes are green. So this is a very important issue, because to know if patient trigger or not ventilation is a good marker to evaluate patient-ventilator synchrony. This is not the case in this picture. As you can see here, there is something like an anarchy in the flow curve. Nevertheless, the ventilator pressurizes correctly, but patient probably is not well ventilated. We go to the bottom of this picture, you can see that there is an increasing leaks in the system. So the explanation for this picture is that there is a higher non-intentional leak that penalizes the quality of ventilation, and patient is not able to trigger ventilation because of leaks. And if you see the top of the picture, you can see that more often the patient is not able to trigger the ventilator. The inspiratory effort performed by the patient and reflected by the flow curve are not followed by a pressurization provided by the ventilator. This is probably a patient ventilatory asynchrony secondary to non-intentional leaks. As you can see in the second part of the slide, there is a reduction in leaks and patient resynchronize and trigger the ventilation because the box as the top of the slide are green. So you can see in this 2-minute page an abnormality of patient-ventilator interaction obtained only by connecting an oximeter in your patients. You can also decompress these trays and see that there is a true energy in terms of flow in this slide that is explained probably by the leak. If you see a panoramic picture, you can see in this patient that over the night there are a lot of periods with leaks, and these leaks are frequently accompanied by the reduction in inspiratory pressure, as a very important leak penalizes the quality of ventilation by impeding the blower to compensate them. In this context, there are very important leaks, and so the ventilator is not able to pressurize the system. In this picture, you can see that there is a maintain of pressurization, but you can see episodic reduction in flow. This episodic reduction in flow are accompanied by a reduction in estimated minute volume as provided by the ventilator. There is not leak. And so the more probable explanation in this context is that patient close the airway, that is, there are apneas under non-invasive ventilation. And as you can see in the top of the slide, this patient is all the time in controlled mode of ventilation. That is, patient is passively ventilated and the airway is closed episodically. This is another example in which there is an episodic amputation of the flow curve. As you can see here, during this period, at the top of the picture, the boxes are yellow. That is, the ventilator is in controlled mode. But the patient is not well ventilated, as is expressed by the amputation of the flow curve, but also by the reduction in the minute volume as provided and calculated by the ventilator. This is accompanied by oxygen desaturation as an expression of hypoventilation. So in this example, there is an episodic reduction of flow that is an expression of airway closure. But in this context, this device is able to show the obstructed airway, but not to determine the mechanism of obstruction. Because when during non-invasive ventilation there is an obstruction of the airway, two mechanisms could account for it. The first is an oropharyngeal apnea, that is an obstruction at the oropharyngeal level. This is the same thing that arrives in patients with sleep apnea, in which there is a collapse of the oropharyngeal tube, and in this context the patient will fight against this obstruction. And you can see in the top of this slide, in which you can see an increasing inspiratory effort as reflected by the thoracic and abdominal belts that are also in out of phase. But there is also a second mechanism that could explain this obstruction of the airway. And this is an obstruction of the glottal level. In this context, patient react against an hyperventilation by closing his glottis. And this closing of the glottis is accompanied by a reduction of inspiratory drive, and so the belts don't move. As you can see in the bottom of the slide, there is a reduction in flow, but no movement at the thoraco-abdominal level. So this difference can only be detected by using thoraco-abdominal belts or esophageal pressure. So, if you come back to the therapeutic goals, what is the place of built-in monitoring devices? They allow us to evaluate oxygen saturation when there is biological marker included in the device, and they are able also to evaluate the presence or not of respiratory events during non-invasive ventilation. That is, apneas, low level of intentional or non-intentional leaks, and maybe optimal patient ventilator synchrony. The next step in evaluate quality of ventilation is ventilatory polarography. Ventilatory polarography is nowadays considered the gold standard to evaluate quality of ventilation. This type of assembly may include at least mask pressure, flow as measured by an external pneumotach, thoracic and abdominal belt that allow us not only to evaluate patient inspiratory effort but also ventilatory effectiveness and oxygen saturation. Recently, some recommendations were published about monitoring non-invasive ventilation by using ventilatory polarography. So, concerning the therapeutic goals, ventilatory polarography allows us to evaluate almost the same elements compared to built-in monitoring device, but probably this tool is better to evaluate patient ventilator synchrony. Last but not least, polysomnography adds to this evaluation the possibility to assess quality of sleep. This is polysomnography that I called the excellence pack. As you can see, there is a complex assembly that may penalize quality of sleep during the night under ventilation at the hospital. So it is possible to propose an algorithm to evaluate quality of ventilation. We will begin by using the basic pack, that is overnight SpO2 combined with tolerable gases. If one or both are abnormal, there is a problem, and we have to move to more complex evaluation of quality of ventilation. And I propose at the first line the use of some built-in monitoring devices that allow us mainly to evaluate leaks, but why not patient ventilator synchrony and apneas under non-invasive ventilation? If both are normal, as I explained, it is not excluded that patient could hypoventilate during the night. So my recommendation is to use nocturnal PTCO2 in this patient or end-tidal CO2 in tracheostomized patients. If all these exams are normal, we can consider that patient is well ventilated. But if the nocturnal PTCO2 is not normal, I recommend to move to built-in monitoring devices as a first-line evaluation of this therapy. After correction of the leaks, we judge that ventilation is not yet effective. We have to perform ventilatory polarography or polysomnography. But when we are able to combine different tools, it is possible more interesting to use non-invasive and not cumbersome tools such as oxygen saturation and capnography combined with built-in monitoring devices to increase the quality of the evaluation of ventilatory effectiveness. So another possibility is to add to this algorithm built-in monitoring devices at the first level of evaluation together with nocturnal PCO2. So, as take-home message, it is very important to perform a step-by-step approach to assess home mechanical ventilator quality. Two steps have to be respected. The first is a routine assessment by using basic bag plus nocturnal capnography. And the second, when there are some problems, is to move to in-depth evaluation. And take in mind that 4 tools are nowadays available to evaluate these patients. Firstly, the basic pack. Secondly, the transcutaneous capnography or end-tidal CO2. Thirdly, the built-in monitoring devices alone or combined with physiological data. And the last and the gold standard is the polygraphy. But as polygraphy is a very cumbersome method and time-consuming tool, I think that we could evaluate correctly a high percentage of our patients by using the combination of oxygen saturation and transcutaneous capnography, and by using the combination of basic pack, transcutaneous or end-tidal capnography, and built-in monitoring devices. So, thank you for your attention.